adjuvant ibandronate in early breast cancer. First results of the TEAM IIB trial presented by Dr. Sabina Lin from the Netherlands Cancer Institute in Amsterdam. Dr. Lin?
Yeah. Thank you so much. First, I would like to show my disclosures. That's common practice in the Netherlands. And it's my pleasure to present to you on behalf of all co-investigators the TEAM IIB trial, a trial that investigated adjuvant ibandronate in postmenopausal women with early breast cancer. So what has been known for a while is that there is an interaction between tumor cells and bone. What we know also is that osteoclasts are involved in bone breakdown while osteoblasts are involved in bone formation. When osteoclasts are active, they release several growth factors from bone that help tumor cells to grow and proliferate. In turn, these tumor cells then release growth factors also, which furthermore stimulates the osteoclasts to become more active. And this is called a vicious circle. So the osteoclasts help the tumor cells to grow in bone and eventually develop metastases. What has also been known for several years is that bisphosphonates can block the activity of osteoclasts, thereby breaking this vicious circle. Recently, in 2015, a meta-analysis was published on 26 trials in over 17,000 women that showed that there was a moderate improvement in overall survival and in breast cancer-specific survival when using bisphosphonates in the adjuvant setting. Now, the TEAM IIB trial was developed about 10 years ago, and the objective was to investigate the efficacy of ibandronate, a new class of bisphosphonates at that time that was 100-fold more potent than the classic bisphosphonate clodronate in postmenopausal hormone-receptor positive breast cancer patients. Patients were randomized between adjuvant endocrine therapy for 5 years or more, and they could receive tamoxifen followed by exemestane or 5 years of exemestane, or they received the same treatment with ibandronate for 3 years in addition. And this was a dose that was registered for the metastatic setting, so it's a high dose, 50 milligrams once daily. And all patients would have follow-up for at least 10 years. We enrolled 1,116 patients, equally randomized between the two arms in 37 Dutch hospitals between 2007 and 2014. Because the accrual was slower than expected, we had to change the protocol. In the original protocol, the study had been much larger. The primary endpoint was disease-free survival at 3 years, and this was defined as any breast cancer recurrence, other malignant tumors, and mortality. Secondary endpoints included time to and rate of bone metastasis as first event, safety, and toxicity. And these are the first results. Of note, not all patients completed ibandronate yet, and we achieved the acquired number of disease-free survival events in August 2016. Also of note, 20 patients never started, and 73 are still on ibandronate. The adherence to ibandronate was 67% at 3 years, which is common for these types of adjuvant treatments. Also for hormonal therapy, we know that this is the same percentage of adherence, and the baseline characteristics were well balanced. In the table, you can see the mortality. In the upper row, all causes, and in all causes there was no difference between the control group and the ibandronate group. Breast cancer specific events were more common in the control group, 29, Then in the ibandronate group, 17 events, and there were 9 secondary malignancies in the control group and 14 secondary malignancies in the ibandronate group. This is the Kaplan-Meier curve of the disease-free survival at 3 years. What you can see that there were 29 events in the ibandronate group and 46 events in the control group. That led to a disease-free survival of 94.3% at 3 years for the ibandronate group and 90.8% for the control group, with a hazard rate of 0.80, which was not significant. For the secondary endpoint, bone metastasis as first event, there were 8 events in the ibandronate group and 23 events in the control group, with a hazard rate of 0.65, which was also not significant. Regarding safety and toxicity, there were more stomach and reflux-related symptoms in the ibandronate group than in the control group, and 20% of patients stopped because of side effects, but these were not only ibandronate-related. 4 patients developed osteonecrosis of the jaw, 0.7%, and it's important to know that all patients, the osteonecrosis resolved in all patients. Regarding renal function, it was overall was stable during ibandronate. There were 5 patients that stopped ibandronate and 2 patients developed renal failure, and it was possibly not related to ibandronate. So this leads to the conclusions that in this study there was no proof of additional effect of ibandronate added to exemestane at 3 years. However, there was a trend towards an improved disease-free survival from 90.8% to 94.3%, and there were less bone metastases from 4.7% to 1.6%. And the drug was safe. There were only some rare side effects. Now this leads to the discussion, and it might be that this analysis was too early, especially for this type of breast cancers, luminal A breast cancers. One might need a much longer follow-up to see the true effect of the addition of ibandronate. It's also important to know that there are still some patients on ibandronate in this study, and the other question is that maybe this study was underpowered. Well, I didn't put an acknowledgement slide, but I would like to acknowledge all patients who participated in this trial and all investigators and the funding bodies to help realize this trial. Thank you for your attention.
Thank you, Dr. Lin. So can you put this in context of the other study, the Austrian breast cancer study group study that showed that zoledronic acid does have an effect in a similar patient population? You alluded to follow-up. I don't know if these drugs are different, size of the study. Could there be other factors that may explain that discordance?
Well, I think that in fact this trial is in line with all other trials of adjuvant bisphosphonates in postmenopausal women. The hazard rate in this trial is 0.80, and in the meta-analysis it was 0.85 for recurrence-free survival and 0.82 for breast cancer-specific survival. So I think in fact this is concordant with what we already know, and I think it's reassuring. It also means that apparently it does not matter so much what type of bisphosphonate you choose, although zoledronic acid is much more potent than ibandronic acid. In the overall analysis, there's not a huge difference in hazard ratios.
Okay, thank you.
That page today. What types of other malignancies did you see in your study, and was there any pattern to them?
Well, to be honest, we are still curating the data, so it's really preliminary, but what we did see was esophageal cancers in the ibandronate group, and it has already been reported that that may be a risk of these drugs. But there were also other cancers that we cannot easily explain why they occurred in the ibandronate group. And of course, there were also secondary malignancies in the control group.
Any more questions? So we just talk about differences among PI3 kinase inhibitors. So maybe there are also differences among bisphosphonates, I guess.
Oh yes, yes. You have the nitrogen-containing bisphosphonates, so the newer ones, more potent ones, and the old-fashioned chlorogenic acid as an example. There are small differences in the molecular structure of these agents, and that lead to a difference in potency.
Yeah. So that's important information, I think, for patients, that they may not realize that not all these drugs are the same.
Now, I think especially the osteonecrosis of the jaw is something that I really fear in my practice. So I always carefully check what is it, the name in English? The elements, so the mouth.
The mouth. Okay.
Yeah. I can't recall the word in. Yeah.
Okay.
But anyway, so and I think if somebody has a high risk of developing osteonecrosis, you should maybe choose an oral agent and not an IV agent.
Okay, thank you.
There's just a quick question about the clinical. What should physicians be doing in this situation? Should they be using a bisphosphonate? Is there enough evidence yet to suggest that this should be clinical practice? Or is it clinical practice?
Well, in the Netherlands, it's clinical practice, although there is a debate among physicians whether you should use it in all postmenopausal breast cancer patients or only in those with a higher risk, because the relative risk reduction is about 18 to 20% on breast cancer specific survival, and if somebody has already a very good prognosis, the absolute benefit from this drug will be minimal, and so it's really weighing the costs and benefits of adding this drug. So in the Netherlands, it's used in high risk breast cancer patients, postmenopausal, but not in low risk postmenopausal patients.
So any comments from the US side? Sarah, do you use it?
I think the other, what we'll do is look at the bone mineral density for women who are going on an aromatase inhibitor. So if we have a woman who has moderate to severe osteopenia or osteoporosis, then we have even more impetus to be utilizing these agents, and we can sell it to our patients as a 2-for-1 benefit. It's improving their bones or protecting their bones while on the aromatase inhibitor and potentially improving their long-term survival. But I agree fully with you. A lot of women won't take it because they go online and read the blogs about jaw rot, which is what one patient called osteonecrosis of the jaw in my clinic. It's frightening when you see the photos of it, and even though it's a very low risk event, it's significant, and your patients do need to be informed prior to going on these drugs of these risks.
I just want to add that actually, yes, there's an indication for bisphosphonates to prevent AI-induced bone loss and treat it, aromatase inhibitor-related bone loss, and it is underutilized because of physician or patient anxiety about potential side effect, which we know that if the patient has had good dental care and doesn't have problems, they will actually do well on it.
But can you clarify that is indication for all of them, or those that have some bone density
bone loss
reason?
Yeah,
Okay.
yeah. So
is that osteopenia, any osteopenia?
So it's actually, so the indication is broad, right?
Okay.
So AI-induced bone loss, and so if you actually theoretically see that the patient has had a decrease in their bone mineral density, you can give it to them on a for prevention. The other thing is that there is, of course, a large adjuvant denosumab study that completed accrual, has not reported yet, and that would be the other bone-modifying agent to watch.
Yeah.
Does that answer your question? We use it less than in the Netherlands, but we use it some.
And I wonder what you think about, because for denosumab, it has been reported in osteoporotic patients that if you stop the drug, then you get an increased risk of fractures. So has an impact on the use of denosumab in the United States?
I think what impacts the use of denosumab in the United States is coverage by
Okay.
insurance. And so although we have an indication for both denosumab and zoledronic acid, we have a hard time getting it authorized, and usually are utilizing oral bisphosphonates
Yeah.
at least first, and then if we demonstrate intolerability to GERD,
Yeah.
for
Mhm.
example, then we can move on to the more potent agents.
Okay, I see, yeah. Well, in the Netherlands, it's also used in the case of osteopenia. Yeah, it's exactly the same.
Well, great discussion. Thank you, Dr. Lin, and I guess thanks to all of you for being here. This concludes our press release.